All right. Welcome, everyone. It's been great to see you again after a long time. Sorry for that. We're waiting for some update from visa, which just came a couple months ago. And we get an access to that so we can start reviewing visa. A lot of things happened this time also that people are submitting question on the WhatsApp group, which is great because this way I know, guys, if you have a specific question, we can answer it. The second thing, Dr. Tanya, she has an excellent case or teaching case about carotid disease. She wants to present it, but unfortunately, she had an emergency case today. She cannot join us. Hopefully, will join us next week. It's a great honor to have two great experts with us here today. We have Dr. Hubballah. He's the chairman and well-known vascular consultant in the Middle East. He is with us here today. Also, we have Dr. Omar Farouk, who is well known from all of you guys. I see Dr. Ali Nahas from Syria also, he's with us here. So guys, I'd like you to take this opportunity to ask some question, So I'm going to start with informal things because I have this great, consultant with us and this benefit from their experience. So instead of starting with a review of visa, I'm going to go through the question being asked on the group, and then I'll give you a time for you to ask any specific question to any of these, speakers. If you know more questions, then maybe we can start. I think it'll be better this way. So let's go through. The first question was on the group, which was from Dr. Abdulhamid Okhda. And the question was that, let me look at here. All right, symptomatic regarding your experience in symptomatic extracranial ICS stenosis associated with significant intracranial MCA segment stenosis. This is a very important question. Like you have patient with extracranial severe ICS stenosis with intracranial ICS stenosis. So what do you do? And patient is symptomatic. So what the best? And this is a very common question. I have one case like that. I'll tell you what my experience, but I'll wait if anybody want to start. Omar, what do you think, Omar?
Yes, it's a very good question. It's a clinical situation that we see. You get extra cranial ICS stenosis with intracranial ICS stenosis. We are trained as vascular surgeon to reach the limit of the skull. Anything inside the skull, we shouldn't do it alone. We should be multidisciplinary. So whenever I get intracranial stenosis, I get multidisciplinary team and mainly with a vascular intervention radiologist with intracranial interest. And I have learned a lot from them. Sometimes the most significant lesion is the intracranial lesion. And this need to be tackled either in the same time with the extracranial or after the extracranial has been solved, but the patient will know that the maximum benefit will get after the intracranial. So each lesion should be treated on its own merit. If I have a combined lesion, I will get multidisciplinary team with me. And in that case, it is case by case decision making. And I have seen multiple variety in this situation. And this is my experience in that.
Thank you. Thank you. Ali, you want to add something?
Good evening, everyone. Good evening, Samer. Good luck. Professor Omar, Professor Hubballah. These are tandem lesions, as we know. They are called tandem lesions when you have one extracranial and one intracranial lesion. Usually they are about 0.51%. This is what I remember from our literature. Usually we resolve the extracranial lesion, and this is important. But for that in the intracranial lesion, I think the collaboration with neuroradiologist, it is beneficial in this case, and you have to resolve it. If you can, it's better, of course. This can be made by stenting using their methods to do that. So as Dr. Omar, Professor Omar said, it's a multidisciplinary effort.
Yeah, thank you. Welcome everyone, and thank you again, Samer, for putting together this very nice review session. As mentioned, these tandem lesions, intracranial pathology, we tend to see them in the forms of either stenosis or in the form of small intracranial aneurysms. And in a case of a symptomatic pathology that we think is coming from the extracranial carotid disease, the teachings have been that if the pathology in the intracranial is not very significant, you would tackle the extracranial pathology and deal with it, and then leave the intracranial for another time. So my tendency, let's say I have someone who has some intracranial pathology of around less than 80% stenosis intracranially, or a small 2 millimeter or 3 millimeter intracranial aneurysm. My tendency will be to do the carotid endarterectomy and leave the intracranial pathology alone. Now, certainly a multidisciplinary approach to discuss all this is very essential, but I would not, try to do both at the same time or do something. I have a symptomatic carotid disease, I deal with it, and at the same time, I evaluate the intracranial. If it is less than 80% or something, then I most likely will not do anything. If it is very tight or something that's more significant, then you may do different things. But this would be my approach to things. Thank you.
Thank you, guys. I'll tell you what my experience was, my case, because I just had to have one case all these years. Patient came to me with about 90% stenosis extracranial, about 90% intracranial. So as you said, guys, I went for interventional radiology, discussed the case, in DT meeting, and my suggestion, as you said, to let me go and do carotid endarterectomy, and then, guys, you go and tackle the intracranial. They told me no, they have a study. The intervention radiology said no, they have a study which showed that even severe intracranial, they don't do any intervention, just medical management. You asked me just to go and do carotid surgery, and that's all. Even if severe, you want to leave it alone. So I did that and did his surgery, and patient did fine. A couple of days later, he had a stroke because the intracranial thrombosed, were severe stenosis. Luckily, he recovered from that. Then I went to literature, and I was surprised to find what he said is correct. For some reason, they have a trial interventional radiology, which for intracranial stenosis, and this trial called, because I remember I read about it at that time, called Sampras trial, and they compare all kinds of treatment for intracranial stenosis, and they found that there's no place for intervention, and they found the medical treatment as good as intervention because intervention has high risk of stroke. So they recommend even for severe stenosis intracranial just to treat it medically. In my case, it did not work, but this is the recommendations. So I think we have to take case by case. But for us, the most important to first to address the extracranial stenosis. I agree with everyone. We have to address and forget about the intracranial or talk to interventional radiology. But this is what I got experience from my, when I talk to them. And I think most of them now, they don't touch it,
Yeah, I would comment on that, Samer. I totally agree. I mean, that's why I said if there's less than 80%, ignore it. But if there's more than 80%, like yours, 90%, there is also a potential thoughts of, first of all, when you do it, you make sure that you have the patient shunted so that you have good flow while you are doing the procedure. And the second thing is you really have to consider that post-operatively, you either have to anticoagulate or dual antiplatelet therapy post-op to prevent that thrombosis event that happened. But I totally agree with you. That's why if you have severe intracranial disease, then medical management for that, and just stick with the external. Thank you.
Let me go to second questions. Here we have him. Management of symptomatic ICS stenosis.
The point, Samer, the point
Go ahead, Ali. Go ahead. We're listening.
Sorry, Samer. The point as mentioned, Professor Hubbala, is to shunt when you do your carotid. I think it is very, very important for our fellows to know that it's important in this case to shunt and to use the Javid or fluid shunt during your operation. This is a point that you have to put it in evidence, I think.
Well, I mean, we are all of you guys, very expertise in carotid. Well, let's talk about shunting because it's very controversial. Let me hear from each one how you do your carotid. Do you shunt all the time? Do you selective? If selective, what kind of monitoring you do for the brain? Ali, what do you do, Ali? Or you shunt everyone? Do you do a local? Do you do general? Do you do nerve block? Because this is all.
I have to say I did many carotids in my career, so, and I used every maneuver of monitoring. First of all, if you do it local regional, it is evident that there is no problem. You control your patient and you shunt when it is possible. If it is general anesthesia, the only method that I get it that will work, I think, it's the backflow from the internal carotid. When I clamp the comb on the external, I open the carotid artery, the internal, and I see by my eye the backflow. Then I decide to shunt. It's empirical method, but for me it is useful. I use it, and I use shunt only when I have a very slow and a very little backflow from the internal carotid artery. After getting 160 the millimeter mercury, the peak systolic the pressure.
So you raise the pressure to more than around 160. I
raise the pressure to 160, at least 160, and I put my clamps. I open the carotid. I see the backflow, and I decide to put the shunt or not. This is the only way that I think it's useful for me personally. It's empirical, but it's useful when I do general anesthesia. In local anesthesia, local regional, I think there's no problem.
You don't measure
it works with me.
But you don't measure
the stump pressure. I have a work with stump pressure. We did it many years ago. It is not so confident to see that stump pressure. Sometimes we have a high stump pressure, and the patient was having problem after surgery, and sometimes we had low stump pressure, and the patient get well. So I think I don't believe that the stump pressure, transcranial Doppler, the EEG, I don't think that one of them can give me so confidence in this case.
Okay, Omar, what do you think, Omar? How you do
so
yours?
I use only the backflow.
Okay.
Yeah.
Omar,
yeah, in my opinion, there are three vascular surgeons, three types. One which is all shunter, all non-shunter, or selective shunter. What I do is the selective shunting. I rely on stump pressure. When it is below 50 millimeter mercury, I do shunt. And the reason I do that, there is complication with shunt. Shunt is not free of complication. And if I get a patient which happened to have a stroke, which is a stump pressure was below 50, and I didn't shunt, I am in a medical legal problem. I'm very eager to hear the opinion, Professor Hubballah, but this is my approach.
Do you do any cranial monitoring or just pressure?
Yes, that's a good question. Yes, I have experience of transcranial oximetry, transcranial EEG, transcranial ultrasound, transcranial limited MRI intraoperative. None of them is totally accurate, but what I really familiar with is transcranial oximetry, which is not an expensive machine, and the transcranial EEG, which is not expensive. You can push the expenses to be much higher, but you don't gain, let us say, you don't gain less complication if you do that. But this is what I do.
My understanding, so you do
Professor Omar,
and TCO2.
Professor Omar, I think
Go ahead, Ali.
Professor Omar, I think stump pressure 50, it's a high baseline. So for that reason, you don't have any problem. The study that I did was about 30. I used about stump pressure about 30. So perhaps your stump pressure is, your baseline is so high, so you don't have any problem when you use shunt or not to use shunt.
You mean why I rely on transcranial assessment of brain function, although I have a good stump pressure? This is your question?
No, he's saying
No,
that.
I was saying that you have, yeah. Go ahead, Samer.
No, go ahead, Ali. It's your question. Sorry.
No, I said that you, as a baseline, you use 50 as a baseline, that it's a high stump pressure.
50.
So you are in safe side, I think. 50, yeah.
Well,
I
that's
think
a good question.
Literature talks
that's a good question.
about 30.
Yeah. Some people have the stump pressure of 30, some people have 50, some people have 70. And there was a very nice study that I've read about it. When you are on the 30, if you have an intracranial lesion on the other side and circle of Willis is not functioning very well, you might get a little bit of more stroke incidence. The one with 70 did show that it has a good result as 50. I follow the, let us say, United Kingdom carotid endarterectomy guideline, which is distributed to vascular surgeons all over UK. And we have, let us say, we have been obliged to follow the 50 millimeter mercury, and we do it by measurement with the machine, the anesthetic machine. We just put the needle and measure the pressure. If it is 50. You are right. If you are 30, it can be sufficient, especially if you have circle of Willis, which is good. And the second part, the stump pressure does not mean that all the brain is functioning very well, because the other side of the brain is like a closed box. The beauty of transcranial oximetry, it gives you assessment of both loops, the right and left loop. And it is, I think, in my opinion, are very, very beneficial to give this. You can have very good result with 30 and with good circle of Willis. I agree with that, but you might run into a risk that if you are on the 50 side, maybe you wouldn't see this much. This is my opinion.
Yeah, I agree with you.
I know a vascular surgeon, I know a neurologist in the United Kingdom, in my hospital, which was Selyoke University Hospital. He was believing that if you do carotid endarterectomy within 9 minutes, you wouldn't get a stroke. You don't need to shunt. You don't need to measure stump pressure. He was like this for 5 years until he hit a stroke. Once he hit a stroke, he was suspended from performing more procedures. So this is just a little bit of history. He was a little bit on the arrogant side. He was very quick. And there is a similar surgeon in Germany which had the same style. If you do endarterectomy within 9 minutes, you are safe without measuring stump pressure and without doing shunting. But they are wrong, and time proves that they are wrong.
I think this is the argument behind Emergent technique, that you can do fast, so you don't need shunting. This is how people who do Emergent techniques, they argue about that.
Yes,
that's true.
Jamal, how do you do it, Jamal?
Well, I had the opportunity to do it in so many different ways. When I was at NYU, we used to do them most under local regional anesthesia, so we were selective shunters. When I went to Iowa, we were selective shunters, but we were using EEG monitoring and transcranial EEG monitoring, and it was very efficient, and we did not have any major issues with that. The only issue was that you need to have the EEG leads placed, and then you need to have the EEG technician and connected to the neurologist, and then they have to review it and you deal with it. Then when I came back to Lebanon, it was a little bit of a difficult thing to get the EEG down to the OR, and it was costly and took time, and there was a lot of logistics. So I started to go with the routine shunting on everybody. So currently I do routine shunting on everybody. Once you do routine shunting on everybody, you get used to it, becomes straightforward and less likely to get flustered when you are doing it. And when you have sudden EEG changes, or the worst is if you are doing it under local regional anesthesia, and when you clamp, the patient may become super agitated and almost get off the table, and try to put a shunt in that situation may end up being a little bit tricky. So currently, this is how I do it. First of all, I don't go by pressure of 160 or 140. I ask, what is the patient's baseline blood pressure? If the patient's baseline blood pressure is 130, I always ask the anesthesiologist to, before I clamp, to bring up the blood pressure just about 10 to 15 to 20 millimeters more than the usual patient's blood pressure. And then I clamp and place my shunt under controlled technique and do routine patching. And I am not a 9-minute carotid endarterectomy. I take my time. I have residents with me, so it takes a little bit longer. And when you have the shunt, it is also a little bit more challenging sometimes to suture around the shunt, but that's how I do it. Now, if let's say I have very high carotid and it's going to be a problematic for some reason, and I think the shunt I may have an issue with the shunt, this is where I have used selective EEG monitoring in the OR so that I avoid putting the shunt and I beef up the blood pressure, etc., like what you have done. I'm curious on your technique of how you measure the back pressure. I have to tell you that I have friends in Florida that use the technique used by Dr. Ali, which is eyeballing the back bleeding. But how do you tell this is good back bleeding and this is not very good back bleeding and this is enough or not enough? Certainly, if you have a pulsating blood coming from the back of the internal carotid, you say I have very good back bleeding. But how do you decide on the pressure? 30, 40, 50? I mean, how do you measure it? I think these are also important questions. So tell us, Dr. Omar, how do you measure your intracranial pressure?
Yes, that's a good question. I just tell the anesthetists they use anesthetic machine, which is dragger, and the dragger can measure like the intra-arterial pressure. So I tell him, can I please have the pressure catheter? He has a pressure catheter which is automatically calibrated, and this is how they measure the intra-arterial blood pressure of radial artery and ulnar artery. And I connect it to a needle, which is a little bit smaller than Seldinger needle, but accurate in measurement. And we have two measurements that he do. One open to air, and he said inject saline, and open to air, he recorded this as open to air pressure. And then I put it in the internal carotid in a slanting way before I do the carotid endarterectomy, and then I will wait until the needle give me pressure measurement with systolic and diastolic waveform, and I get the maximum systolic, and this is the 50 millimeter mercury. It is done by the
and when you
anesthetic
do
machine.
that, do you have the common carotid and external carotid clamped, or they are not clamped when you do that?
Yes, they are clamped.
Because that's an important thing.
Yes.
People.
Yes. After clamp, yes, because
I'm not asking. I'm mentioning that so that the fellows and junior faculty who are listening, they will know the technique, because there are different ways.
Yes.
But it's very important that
Yes.
you have the common carotid clamp, the external carotid clamp, and some people put the needle in the common carotid, and that measures the back bleeding coming from the internal. But you could argue that the stenosis may alter the actual pressure. But there are various techniques, and obviously they have to realize this. The residents have to realize that you have to cross clamp the common carotid, you have to cross clamp the external carotid, and then put your needle either in the internal carotid in good position and make sure you have a backflow, or in the common carotid, so that you don't screw up the internal carotid by your needle or anything. But
the consultant that I did,
these are important technical things. And
Yes.
ultimately, everyone has to decide on the technique that works best in his institution or her institution, and the technique he or she are most comfortable with. I think you all.
Absolutely right. Because if I am measuring while open common carotid, external carotid, this is not a stump pressure. Stump pressure is the pressure in the internal carotid artery when it is supplied by circle of Willis from the other carotid territory. And this is the back pressure. The consultant that I worked with before me, he didn't believe in stump pressure. He used to put his hand in the internal carotid artery. If it is pulsating, he said, this is good. And then he proceeded with it. And he was good. His name is Magdi Obeid in Birmingham. He was very good vascular surgeon, but he never believed in the measurement of stump pressure. But after that, we started to believe in stump pressure more than our fingers. So even if you get pulsating internal carotid artery after ligation, this does not mean that you have a good stump pressure. The only parameters that we use is intra-arterial measurement using stump pressure. The question becomes more confusing if you are having the skills of carotid stenting and intracranial stenting. So you have 4 options with tandem lesion, and then it will be a big dilemma. I have done, I think, around 5 intracranial angioplasty. After I've done carotid endarterectomy, it has to be done under general anesthesia, and you don't cross the millimeter balloon of 2 millimeter balloon. You don't do
In the same
oversizing.
setting, you've
and
done them in
risky.
the same setting?
No, not in the same setting. No,
Yeah.
on separate setting. Yes, on separate setting. Because when you're having a tandem lesion, we know that internal carotid artery doesn't have branches. So if you clear the 90% stenosis and you have 90% intracranial tandem with no branches, you actually hemodynamically did not offer any benefit. And this is when I discuss it with the intervention neurologists. And they are very good. They have very good skills. And sometimes between ourselves, we can manage what is the best we do. But stenting, obviously, you have made situation. Sometimes it's a lot better to do everyone separately, not to do both of them at the same time. Regarding what happened to Samer with his case, although he was unfortunate, but I would have done what he has done. I would have corrected the common carotid, the internal carotid artery extracranial, observe what happened intracranial, because this lesion can become more aggressive because you're hammering a lot of blood, a lot of platelets. So if this was 70% stenosis, it will become 90% quickly within 1 month, and then he can stroke. So I think what he has done is right. I know the paper that he was describing, but this is, let us say, not on the World Authority agreement. So this is a little bit debatable, but what he has done, I think, is right, although it was unfortunate for the patient.
I mean, the problem is that they have this is a strong trial according to them, and they said very obviously that even severe stenosis they treated medically. So I don't know.
No.
I'm not a radiology.
Well, one of the best carotid courses in Germany is the one by which is a very famous cardiologist. I can't remember his name, but he do in Frankfurt a course twice per year, one in German, one in English. Horst Sievert. His name is Horst Sievert. Horst Sievert is one of the best to do intracranial intervention. And with a special technique, with a special training, although he is a cardiologist, not a neurologist, he has a beautiful result. And his opinion that intracranial lesion should be dealt with by a cardiologist and not intervention radiologist, because in Egypt, we have only 10 intervention radiologists. But if you open to cardiologists, because you need to correct within 6 hours from the stroke, this is the brain-saving time or brain-saving procedure. So I think this paper, I have to go to see how old it is and what tools they have used. But nowadays, if you have intracranial lesion, it is a very high stenosis, it is amenable to correction.
Omar,
Horst Sievert is the name. Yes.
You cannot depend on one person's experience to get a conclusion. This is a trial. larger trial really, and they showed very clearly that there's no advantage. Even so, we have to go with that. Especially for junior. I'm talking about the junior because they may get in the exam. So in the exam, we read these trials. I don't know, but this is a trial. You may need to go and read it, and then. But it's not our field anyway. It's not our field, so I cannot.
Yes, absolutely. Yeah, absolutely. We say for FRCS vascular exam in United Kingdom, if you've been asked about a lesion intracranial, your best answer to say, I know a very well intervention radiologist that I will refer this case to him. And you are absolutely right. For junior staff, don't touch anything inside the skull is the advice.
All right, so as you see, guys, there's a lot of controversy about the shunt, not shunt, selective shunting, and this was I tell you there is no difference really, and because nobody showed the difference, because if there is a difference, then we have only one technique, but because different techniques, that mean all of them they work, So you can pick up what Professor Jamal said, what fit you, what you guys are going to see multiple technique, you pick up what's the best you think in your hand. But really, nobody can tell you my technique is better than the other technique. Shunt, all the shunt, temporary shunt, everyone has his own pros and cons. So this one, we always leave it to the physician discretion to decide which way to go. But you have to have something. If you decide not to shunt, then you have to have something monitoring. But you cannot don't shunt and don't monitor, So if you decide to shunt, then everyone, they don't need to monitor. But if you decide not to shunt, you have to have one way of monitoring, as a TCBO2, pressure, stump pressure, EEG, anything. All of them, I think, the same. Doesn't matter, depending what local.
And remember that in general, when you do selective shunting, you realize that only about 15% of the patients will ultimately require selective shunting. So that's why in almost 85% of the patients, you will have no need for a shunt, and you can get away with either technique. But the key is to identify those 15% that will require shunting. And if you have a good way of identifying it, excellent. If you don't, then you are likely to shunt 85% unnecessarily, but you get used to it and life goes on. Thank you very much.
The other indication for shunting, if I'm working with a fellow, because this way they can take their time, So if the fellow scrub with me, I like us to put a shunt, so be no rush. He can take his time. He can do his nice surgery.
Yes, absolutely. I mean, we are all in teaching institutions with fellows, and this is how, whatever. But anyway, what other questions do you have?
You make it more difficult when the shunt is in the field for the fellow.
This is correct.
I think, yeah.
But they have their time. They can dissect slowly. Suture takes their time with suturing. Yeah. But yes, not really, but it's, yes, make it a bit more difficult here. All right, so second question, management of symptomatic ICS stenosis with vertebral artery disease. Like you have vertebral artery stenosis and ICS stenosis. The problem, and the question I understand which one is symptomatic, is vertebral or ICA. But if you have both, you do them both, or you just how do you approach that?
That's a very tricky question. Do you want me to fire on?
Yeah, go ahead, please. Anyone.
Okay. Vertebral artery, the problem when you get a stroke after vertebral artery intervention, it will go to respiratory center. It can cause sudden death. And this is the danger of vertebral artery, either by stenting or by any way of surgical mean, which is vertebra is very difficult to get vertebral zone 1 to get intervention. This is number one. If I have patient who is symptomatic, both internal carotid artery and vertebral artery, and not that the area of symptom, because if he has, let's just say, amaurosis fugax, this is carotid territory. If he has hemiparesis, this is carotid territory. But he must have let us say, the brainstem symptoms. And this brainstem symptom can be nystagmus, instability of gait. So let us say that the symptom is due to the two territory of them. I never treat them on the same setting. I know cardiologists in the United States called Steve Rami who do it on the same setting, but he's arrogant. So what I do, I would discuss it with neurologist. These are the territory symptoms that he has. If I never seen it equal, it's either dominating carotid symptom or dominating vertebral. In my experience, which is limited, not far, I haven't never seen it equal. So if he complain of, let us say, walking stability or the brain stem more symptom, I would treat his vertebral first. If he's having more carotid symptom, I will treat his carotid first. And I never treat both of them on the same setting. And I always get intervention neurologists with me. I like them when they do the neurology exam before the decision of the procedure. And when they look to the MRI and they decide the ischemic area, which affect our decision making. We can do carotid vertebral both by stents and both by open. And this will be my answer. And so it's a bit long.
All right.
I can tell you the teachings and when I used to be in the oral boards in the US, when you have combined anterior and posterior circulation, our typical approach was always to fix the anterior circulation first, see if the patient's symptoms go away. If they go away, excellent. If they don't go away, then consider doing the posterior circulation. I continue to do that. I will never do a combined anterior and posterior circulation procedure. I would just, it's hard. It's if you have symptoms related to posterior circulation, but you also have the anterior circulation. Sometimes by fixing the anterior one, you will improve the flow through the circle of Willis, and you may get that posterior circulation symptoms resolved. It's much easier, less complex, less risky, and that will be my typical approach. But that's how we have been doing it we did it in the US. Thank you.
I agree with you, Jamal. I'll do the same. And this was a teaching, as you said, in the exam. Always use the external first, then you do the vertebral. Don't do them the same time. The guidelines very clear. Same time, because vertebral disease is not embolic, it's like low perfusion. So as Jamal said, when you fix the anterior, most of the time maybe the posterior, symptoms may disappear or improve. But always start with the extracranial first. Right, Ali?
I agree with you. We have, as Dr. Professor Omar said, that Professor Hubballah, these are two territories, one anterior, the other posterior. So the surgery or the treatment of the vertebral artery, and in some cases we see stenosis of the basilar arteries. I saw one year ago. I think fixing the internal carotid artery would be sufficient in these cases. So we do a little number of vertebral arteries stenosis.
Next question is what the management of acute stroke, immediate post-carotid endarterectomy? Like you do a surgery and they may get a stroke. I think this is a very common questions. I think it depends. The question did not specify where are you? Are you still in the OR? Are you in the recovery? Are you on the floor? Because the management completely different. It depends where you are. Let me to talk. Somebody else want to talk. Omar, you want to say what you say? What do you do, Omar? If you are in the OR and patient wake up with a stroke.
Yeah. This is after carotid endarterectomy. Is that right?
And you are in the OR. The OR.
Yeah. If I am in OR, usually I get the duplex straight away and measure and see. I usually do my own carotid duplex scan. So I scan the duplex to see my suture, if there is any hematoma, if anything happened. If I found that the anastomosis have thrombosed, which I have seen it, then it is back to theater. The quickest way I can get the flow back again, the recovery will be much better. And the tricky part, when I found that the carotid endarterectomy is fine, but there was a bit of emboli that went into one of the intracranial branches, either M1, M2, or M3. Then I will call a neurointerventionist while I'm in OR. They usually have a 24/7 rota if you are doing carotid endarterectomy. And now the preferred tool is penumbra. Usually they go with penumbra because there is a contraindication for ornithrombolytic therapy post-operative. And with penumbra, they can follow the artery until they get the clot out, or at least push it into less symptomatic part. And this is what happen if I am in OR.
This is in the recovery, not in the OR, right?
If I'm in recovery, yes. If I'm in recovery, yes.
And if you are in the OR, the same, you get an ultrasound duplex.
Yes, I get ultrasound duplex while patient is on table. And if everything is clear, then the reason of the stroke is intracranial, then I will get femoral sheath and quickly get an access and ask someone to get a neurointerventionist quickly. I have used the penumbra, but I wouldn't recommend at all to be done by vascular surgeon. Always do it with intervention radiologist experienced in doing penumbra clot extraction.
So if you're in the OR, you don't just go right away and open the surgery.
No, I get duplex scan. It gives you a very accurate information about hematoma, about suture, about leakage, about intracranial, extracranial. I measure the peak systolic velocity. I know exactly my operation, how it went, and that is why I do my carotid duplex scan. I just put that's why I put an opsite on the carotid. I don't put gauze. And then you can put the gel on the opsite and you get a fantastic picture. Sometimes I can actually count my stitches with the new duplex machine, Vivid E and Vivid I. You can count your stitches. This is how accurate it is. And then it will give you information till internal carotid. If everything is fine, then you need to put a femoral sheath, get intervention radiologist, get penumbra device, and go to get the clot out if you are in the OR.
Jamal, what do you do, Jamal? Same?
You know, I think some important points have been made here. Is that what is the cause of the stroke? The cause of the stroke can be internal carotid thrombosis, especially if you have had a primary closure or if the plaque was high up and you don't think that you could tell from the surgery that what could be the causes sometimes. So it can be internal carotid thrombosis. It can be emboli. It can also be intracranial bleeding or hemorrhage, or ambuls that happen. So it's very important to determine whether the carotid is open or not. I think I would go with a duplex immediately and get the vascular lab. I'm not as good as Dr. Omar in doing my own duplex, but I will get my vascular technician who's very good at doing it. I would look at it and make sure if it is open or not. If it is totally open, then my inclination will be to take the patient for CT scan and get a CT angio and get a better understanding of what's going on. And according to that, at the same time, contact my neurointerventional radiologist for exactly what Omar said, which would be to put a catheter in and do a penumbra, or depending on what the pathology is, and go with that. If it is an intracranial bleed, then it's a totally different situation. So this is what I would consider doing. Now,
Right.
I have to tell you that the teaching before used to be that immediately if you have a stroke, you take the patient direct to the operating room, open and explore. But I think, and this used to be the teaching at NYU and the teaching at other places. But and you open up, and how do you evaluate? Do you have to open the patch? Do you have to listen with Doppler? Do you have to do an intraoperative angiogram? So there are a lot of nuances of what to do when you, and then if you're gonna open directly, you have to re-intubate the patient, put the patient under general anesthesia, etc., etc. So there are a lot of issues. That's why I'd like to determine if it is open or not open. If it is open, then I don't need to take the patient to the operating room. If it is closed, thrombosed, then definitely my situation, I have a technical problem. I open and extend my arteriotomy, do more endarterectomy, better patch, etc., etc., etc. But these are my my current thoughts on how to address this. Thank you.
Thank you very much, Jamal. So just to summarize it to the fellow, so the first thing we do a duplex ultrasound. If it's negative, then CT scan throughout intracranial bleeding. If it's negative, then intervention neurologist for embolectomy. Correct? So this
Absolutely.
will be the fellow in the question, the exam. All right.
Yes, and embolectomy by intervention radiology, by an interventionist, not by us. I mean, you should never, as vascular surgery, should never try to do an embolectomy. Don't you ever think of putting a Fogarty catheter inside the internal carotid and try to do an embolectomy? That would be the best way to have a disaster. So yes, you can get an interventional radiologist, cardiologist, neurologist, interventionist, neurosurgeon will get their wire up. There are several techniques to get the clot out, penumbra or other techniques, and they have to deal with it.
I think there's a good question here. We face it a lot. Management of inadvertent insertion of central line in the common carotid artery. We've been called many times. They put
That's a beautiful question.
Yeah, what do you do? And it's a lot. I'm telling you, I see a lot of them, you know. So let's say Ali. Ali, we didn't hear his voice. Ali, how you do with that? They call you.
Yeah. First of all, to have your air pathways are free. This is to assure that, first of all. I think if the hematoma is increasing, then you have to explore it and put the stitch on the common carotid artery.
You still have central line there. It's not the hematoma. They put a central line and
when you
the common carotid instead of IG.
Yeah.
Central line is no hematoma. Central line there.
See, and when you take it out.
So do you take it out or not? This is a question. What do you do? They call you. The central line is there in the common carotid. Do you take it? Do you leave it up and take it? How do you push that? Because it's happening.
It's better to take it out in OR, I think, in operating room, I think.
Okay. What do you do, Omar?
The theater. So
yeah, it's a good question. This is a good question. I usually the vascular surgeon who have a good deed with anesthesis. Sorry.
Sorry, Ali. Go ahead, Ali. Sorry.
I think
that's okay.
It's better.
Okay. Omar?
Okay. So
they usually, yeah.
No, please go ahead, Ali.
I think it's a connection.
No, nothing. I was saying that they usually call us when they take it out. So when the hematoma is already present.
Okay.
This is the problem.
Omar, what do you do, Omar?
Yes. Number one, it's a very common request to get a vascular surgeon and you tell him that my CVP went into the common carotid. This is a common request. So number one, what I do, I don't remove the caster. I ask for CT scan. CT scan, and I discuss with the CT scanner. I tell him I need not just 5 millimeter, I need 1 millimeter cut section in the whole area to cover where the puncture has happened. Is it anterior wall, posterior wall, common carotid, external carotid, internal carotid, and I have seen all this variety. This is number one. If I remove it and I don't have a femoral sheath with the covered stent in that area, then I wouldn't control it, especially if it is in a surgically difficult or inaccessible situation. Usually, the common carotid is an area which is accessible to us, but I have seen people doing it really very near to the thorax, to the chest. Is that to get a good control, you need to have a thoracotomy. So number one, I decide where the puncture has happened. This is number one. Number two, how to secure it. I prefer the endovascular option by transfemoral sheath. I get a covered stent exactly in the area which had been punctured. And usually I cover it by 4 centimeters. And then intraoperative, I remove the caster. And then by imaging, if there is bleeding, I will pull my covered stent. If it is in a surgically accessible situation, which let us say zone 2 in the neck, common carotid, anterior wall, then I put him local anesthesia. I will open everything up. I know that I can control it with a couple of stitches, and then I will remove it under vision. There was one case which I have used a closure device, which we had a closure device at that time, and it was very nice lesion in the common carotid artery anterior wall, and I was able to put the guide wire, take it and put the closure device and then secure it from inside. But I did have a backup plan with a covered stent if this didn't work. So this is what I do. They are difficult cases. Secondly, you must mention everything you do in the notes, because these cases will go to medical legal court. And you must say exactly what you have done. When you have seen the patient, every move should be recorded. Number 3, you should be honest to the patient, because he will tell you, did the doctor put the caster wrong? Did the doctor rupture my artery? Did the doctor blah, blah, blah? You must be very, because this is an ethical dilemma and the surgical skills dilemma. And usually there will be an added cost as well. So I've been involved in I would say, a lot of these cases. So this is my reply, and eager to know, Professor Huballa and you, Samer, what do you do?
What do you do, Jamal?
Yeah, we've been called on many of these as well. I think there are several things that go into the consideration. First of all, is the patient intubated or not intubated? Many times the patient is already in the ICU, intubated with an endotracheal tube, and they're trying to put a neckline, and they put it in the carotid artery. Second thing is the patient receiving any anticoagulation or not. Sometimes those patients have a PE, DVT, whatever, atrial fibrillation, and they are also on anticoagulation. If they are anticoagulated, I think that the idea that of getting a CT angio is a very good idea, because you will know better where you're going. But to be honest with you, most of the time, 95% of the time, the puncture is in zone 2, and it's very rarely in zone 1. And if you really cut down on it and follow the catheter, you will follow the catheter, keep going down until you get to where the hole is and where this thing is going into the catheter, and you can dissect around it, etc. So I have not done the endovascular technique that you are describing of going in the femoral and trying to get a sheath up or something like that, because I think that I'm not that comfortable with it and not that excited to put a stent graft in it. I have used that technique if I have someone who has had a subclavian line going to the subclavian catheter. Then I put a brachial catheter sheath in, introduce a balloon, introduce a wire, a balloon, pull the sheath, inflate the balloon, and wait and see what happens, and have a covered stent ready for that. But for the carotid, no, I have not. Also depends on the size of the sheath or the line. Sometimes you have patients that have had a cordis catheter, cordis sheath, that the one that you place to put a Swan-Ganz catheter is like a 7 French or 8 French sheath. That's something I don't feel comfortable. But if you have sometimes just one single lumen catheter anteriorly, patient is not anticoagulated, etc. We've had patients where we had removed it, the patient was fairly sick, but intubated, and with duplex compression on the puncture site, it was anteriorly, and placed duplex compression on it, and it subsided and nothing happened. So I think you have to take all these into consideration, see what's best. What I don't want to do is to become the one who is to be blamed for the complication. So that's why I will not hesitate to take the patient to the operating room under local anesthesia, general anesthesia, do a good exploration, put a few stitches, and come out. No need to make a complication twice, that will be my typical approach to that. I would wonder what Samer has been doing.
Shukran, Jamal. Yeah, we saw a couple of cases, and unfortunately, most of our cases was zone 1 was really low. But anyway, first thing is we depend. First, I think I agree with Omar is that we need to get a CT angiogram. We always do CT angiogram because you want to know how low. Because sometimes be surprised how high is a puncture, and they go. I don't know how they do that, but they go really very low when they puncture. So this way, at least we know where is the entry side. And then depend, if the catheter is very small, as you said, if it's like 4 French, or 5 French, usually you can put it and put a pressure, but sometimes if it's like low in zone 1, we put like a balloon just in case something happens, at least we have a control on the bleeding. If it's in zone 2, I just take it out, I put a pressure. If any bleeding, as you said, we just make small cut and we can fix it. If it's large sheath, as you said, Jamal, if it's zone 2, just make small cut and fix it. If it's zone 1, then I'll put a cover stent there. I'll just make it ready. And then we pull the sheath and we deploy it right away. Because this is a big, no way it's going to heal. And you don't want to get, as you say, you want to make it more complicated. So if the large, we do a primary stent, cover stent.
Yeah, I agree with you. If the zone 1, I mean, that's because zone 1, I mean, it's an endovascular treatment no matter what you do. I mean, this is the typical thing to be
like that. Only I have one case where we went to subclavian artery, and this one I do the closure device in subclavian artery, and it worked fine, But in carotid, I never tried closure device, I think, I know, it's just risky, I think. But my question is that if they call you middle of the night, is it safe to put patient on heparin and deal with that next day, or you have to come middle of the night and do it because of risk of embolization? I think this is always question our mind. Like you call you 2 a.m. in the morning, the patient have it, they found it. Can you put patient heparin and deal with it next day, or it's better to come as soon as possible and take it out?
Yeah, that's a good question. It's been answered by CPOD report, which mentioned there was a problem in United Kingdom with non-real emergency cases done at 2 and 3 a.m. So they made a study all over United Kingdom, and the only one condition that you should do after 12 o'clock, which is rupture AAA. Anything else, a lot better to be wait until the morning with a full staff, the anesthetist, if he is hemodynamically stable. If he's not hemodynamically stable, then situation change. So according to CPOD report, which is very nice report, I think it's about 9 pages, to avoid mistakes, I always, when I've been called at 2 and 3 a.m. in the morning, I always remember CPOD report. Is it really indicated to do it now, or is better to do in the morning? I usually resuscitate, get little bit of blood, platelets, preparation, tell patient, tell ICU, tell doctor. Usually this talk will keep you until 9 o'clock in the morning. At 9 o'clock, then you can start. Unless you feel that you are losing the patient, which I haven't seen with this type of injury. So this is my answer.
No, the question is that, do you think there's any risk of embolization? This is the main question. If you think if we wait till next day, is any risk of embolization to the brain and get like a TIAs or something like that, or you think the risk is very low? And should put patient
I think there is definitely no question. It's a foreign body. It's an injury to the intima. So brain embolization cannot be excluded. While in my experience, I haven't seen it. Usually the problem is bleeding rather than embolization to the brain. And usually these patients are anticoagulated. And if you go in quickly, you don't wait until you see embolization. I haven't seen in my experience embolization from this type of injury.
And I think the idea of these are good points and challenging points. I agree with Samer, and I agree with Omar, that Dr. Omar, I wouldn't take someone in the middle of the night because of a line in the neck, but I would anticoagulate because I think it is thrombogenic catheter, and clot can form around it, and then even removing it will become hazardous. So I think I would make all the necessary plans, get the CT angio, get the studies, get the OR prepared, and do it electively in the morning, anticoagulate, and do it. That's what I would consider.
Great. All right, guys, it's been an hour now. It was a very nice discussion. Thank you very, very much. I really appreciate that because I took that opportunity today because we have a great, experienced, consultant with us. So to go through all the questions. Any question from the attendee before we leave? Anyone has any questions? And we're going to continue next week with carotid. I mean, we'll be a couple of weeks in carotid. So anybody has any more questions, just write it down and we'll discuss it next time. But for now, thank you very much for your attendance and we'll see you next week. Thank you, Jamal. Thank you, Ali. Thank you, Omar, everyone for attendance. And good night.
Bye-bye.
It was a pleasure. Thank you.
Good night.